Are Robin, Dave, and Tom here? It's Tom.
Hi.
Morning.
Morning.
Morning. All right, it looks like we have everyone. I'll call to order the Green Mountain Care Board's hearing of December 13th, 2023. Today we have four agenda items. We have the Medicare benchmark proposal. We have One Care Vermont's fiscal year 24 budget deliberation. We'll then have a lunch break, and then we'll hear from Pat Jones from the Agency of Human Services and Michelle Degree for our monthly all-payer model and global payments update. And last but not least, we have a potential vote noticed and a presentation by Kate O'Neill on the HIE strategic plan and connectivity criteria. I apologize for the delayed start. I had some internet issues here, and I apologize for that. One other scheduling note is that Marissa Melamed will present the One Care presentation and the potential vote. Miss Sawyer was planned to be out and is out today. And so Miss Melamed will present, and Miss Sawyer will be back next week to wrap up the One Care 24 budget agenda items. So that'll turn it to our Executive Director, Susan Barrett.
Great, thank you, Mr. Chair. Good morning, everyone. Just as a reminder, the Green Mountain Care Board does take public comment throughout the year, but we do have often special public comment periods. They're all listed on our website under our public comment tab. I'll review them briefly for you as a reminder. First, the board received Brattleboro Retreat submission of their FY 2024 budget. This is a new duty that the board was asked to perform by the legislature. We received those materials on December 4th. They are posted. We're asking that if anyone has any comments, they share those comments on that budget submission with the board. The board plans to hear from the Brattleboro Retreat next Wednesday, December 20th, and the vote is planned next Wednesday as well. So we'll be accepting comments on that submission through December 18th. We also continue to accept public comments. I'm sure Marissa will highlight this during her presentation, but through this Friday on the One Care Vermont submission, their budget submission. So please get those in so they can be considered by the board ahead of their vote, which is scheduled on December 20th. And as another reminder, we are still accepting public comments on two ongoing items: the hospital sustainability work. We wrapped up our community engagement, the first round, about a few weeks ago, but we are still accepting comments on that work, and they are all posted on our website. We had a request to post those, so if folks want to take a look at those really meaningful comments, I'd recommend checking out those on our website. And then last but certainly not least, we are accepting public comments on a next potential model with CMMI. We share those comments with Agency of Human Services as they are leading the current model as well as the negotiation on any potential future model. And then scheduling wise, we have our last meeting of the year planned for next week. We intend to be wrapped up by next week. And that would be our last meeting of 2023, and we'll take a well-deserved break for everyone over the holidays. So with that, I will turn it back to you, Chair Foster.
Thank you. Before we turn to the presentation, I'd like to bring up the minutes from December 6, 2023. Is there a motion to approve the minutes?
I move approval.
Second.
And all those in favor, please say aye.
Aye.
Aye. Aye.
Aye, and the minutes are unanimously approved. Our first presentation today is on the Medicare benchmark proposal, and it will be presented by Michelle Degree, the Green Mountain Care Board's Health Policy Project Director, and Lindsay Kill, our Data Analytic and Information Chief. So I'll turn it over to you guys.
Thank you, Chair Foster. I just want to confirm, can everyone see my screen and can you hear me okay?
Yes.
Thank you. I apologize. There's been some connectivity issues here at the office too. So if I drop out, I promise I'll be back. I'm doing the best we can over here. So yes, as Owen said, myself and Lindsay are here to present to you on the 2024 Medicare benchmark. This is our staff recommendation. As Susan just noted, we have a vote scheduled for next Wednesday, December 20th. As a reminder, the decision made on the Medicare benchmark goes into the ACO's participation agreement with CMMI or Medicare and needs to be signed and fully executed by the end of the year. Just a quick overview of today's agenda. We're going to start with our staff recommendations and also conclude with our staff recommendations. And in the middle, we'll walk through sort of the way that we came to that decision. So right off the bat, here we go. The staff here are recommending that we use the maximum allowable trend for OneCare's Medicare benchmark. Per the agreement, this is 0.2% below the national projection. So that ends up being 4.3% for non-ESRD populations and 6.7% for ESRD or end-stage renal disease population. And that would translate to a request of advanced shared savings of $9.9 million. Lindsay will talk in a little more detail later about the breakout of those specific percentiles, but just starting off, staff are recommending maximum trend this year. Couple of trade-offs for using that maximum trend. Pros, we've continued to hear that Vermont hospitals are fragile, and that's a trend that's observed nationally. The maximum trend will increase the amount of federal dollars available through the agreement. So as I just said, we're asking for almost $10 million in Blueprint and STASH money this year. The con, the big one to think about, is the maximum trend could endanger the ability of the state, so the state's all-payer model agreement, to fulfill its financial targets in the all-payer model. We list it here every year because it is a concern. However, we don't think that by recommending max trend, we don't think that we are in danger of kind of a triggering event in this space. I'm going to turn it over to Lindsay to talk about some previous decisions the board has made.
Thanks, Michelle. Good morning, everyone. My name is Lindsay Kill, and as I said, I'm the Data and Analytics Information Chief. Just to review some previous trend limits and the GMCB's decision related to those trend limits. 2018, 3.5% across the board, both for non-ESRD and ESRD. We elected to use the floor provision of the agreement in that year. In 2019 and in 2023, so last year, we did recommend the maximum allowable trend from the federal trend limit. In 2020 and 2021, of course, was the public health emergency, and we received, we came to agreement with CMMI that we would use retrospective trends due to the public health emergency, and so that's why there is a federal trend limit, but as you can see, the approved benchmark trend is very different. It's because we used a retrospective trend. So after the year was out, we looked back on actual performance and just used that trend. And then in 2022, the maximum trend from the federal trend limits was 10.4 and 7.6. For non-ESRD and ESRD respectively. And we recommended and the board adopted a 7.3% trend for both groups. And that's because we opted to use the base experience with imputed values during the public health emergency. So that increased the baseline experience value. So we opted to use a slightly lower trend instead of using a high baseline experience and a high trend. This did turn out to be beneficial, and I believe that the net to the ACO from that was $457,000. Next slide. Oh, back to you, Michelle.
with that, I'm going to go through a little bit of background, just as promised, and a little reminder to folks of where we are. So an overview of sort of all of the agreements in place. As I mentioned earlier, the board's decision here goes into the ACO's contract with CMMI and Medicare, so their payer contract listed here. We have the Vermont All-Payer ACO Model Agreement, which is the state's agreement, and we'll talk a little bit about that in the next slides. Again, a reminder of how we measure the all-payer model. We've got 3 areas of performance that we monitor and report out to our federal partners. We have total cost of care, which is the financial yardstick; scale, which is the proportion of the population aligned to the ACO; and quality. And today, we're specifically talking about performance under the TCOC portion of our reporting requirements, and the red text is sort of where we are today. So the Medicare ACO aligned population is the state's entry point to regulating healthcare for Medicare beneficiaries. And the Medicare benchmark is how we fund, again, the piece of Blueprint for Health and the SASH program in the state. The all-payer model financial targets. So there's the state of Vermont accountability listed here. Again, we need to fall within a 3.5 to 4.3 average. So that's that compounded annual growth rate from 2017 through the end of the agreement. So through the end of the extended agreement term, that did not change with the amended and restated agreement. And the Medicare TCOC per capita growth needs to, again, compounded annual growth rate, or CAGR, needs to be from 0.2 below to 0.1 above national projections. And the duty that we're here to talk about today, again, is ACO's Medicare benchmark, which is the annual growth target for Medicare beneficiaries that are attributed to, in this case, OneCare Vermont. ACO financial targets. Medicaid and commercial payers negotiate those targets annually with the ACO, and the GMCB uses our ACO oversight authority to monitor those targets and how they relate to those financial yardsticks. For Medicare, again, we're relying sort of on the GMCB's proposal for that financial target increase. The agreement includes criteria that the proposals have to meet, which are included in what Lindsay and I present to you here. And then CMMI approves or can request modification to the proposal. I'll turn it back over to Lindsay to talk about the benchmark components.
Thank you. So just to review what goes into the benchmark calculation. So per the agreement, we have to use the most recent year of data. Currently, that's 2023, but we're not done with 2023, and we don't have all the data for 2023. So instead, what we do for that first piece for historical experience is we estimate the medical claims spending in the calendar year for 2023 for the beneficiaries who would have been attributed to the ACO in this year, based on the 2024 ACO network, and we call this the benchmark reference population. The big reason to do that is to get a full picture of the cost of mortality. End of life is very expensive, and without the full run out from the year, this is the best way we have to estimate that. That number is a per beneficiary per year dollar amount in medical experience. And so that gets multiplied by the number of beneficiaries who are aligned to the ACO, who are, prospectively aligned to the ACO for the next year, so for 2024. This number is also what we use for ACO scale participation for the coming year. And then those two things are multiplied by the trend factor. And this is really the GMCB's decision. So this is the estimated change between the 2023 benchmark population to the 2024 actual population for the ACO attributed beneficiaries. And the multiplication of those three things together creates the total benchmark for the year, which is the financial target for the ACO. Next slide, please. So per the agreement, the trend set by the GMCB must meet a certain criteria. One of those is that the trend is at least 0.2% lower than the projected growth for Medicare fee-for-service nationally. Those national projections are from the Medicare Advantage call letter that's released every year around April. So we have those numbers and we work with them throughout the year on projections. So for example, for 2024, the trend for non-ESRD fee-for-service Medicare expenditures was 4.5 nationally. Vermont's maximum trend per the agreement is 4.3. Next slide, please. And just a note about end-stage renal disease versus non, the Medicare benchmark is set separately for beneficiaries who are eligible due to end-stage renal disease versus the remaining population who are eligible due to age and or disability. In this ESRD population, there are very few beneficiaries, but their average expenditures are much greater than the remaining population. So that's why the benchmark is set separately for them. And the final benchmark, as we usually talk about it, is the blend of the two populations. Next slide. Okay, so the benchmarks and the AIPBP. So we just like to remind people every year of this because it is really confusing. So the Medicare offers a prospective payment called the All-Inclusive Population-Based Payment, or the AIPBP. These payments are designed to provide cash flow to providers that gives them more stability during the year. So it's upfront for those ACO-aligned beneficiaries. Ultimately, that payment amount is reconciled to what would have been paid on behalf of those attributed beneficiaries in a fee-for-service arrangement. So the total, when we think about the total Medicare ACO total cost of care, it's the fee-for-service payments plus the AIPBP claims. But the Medicare AIPBP is calculated separately and reconciled independently from the benchmark, what we're talking about today. I'll let you do this one, Michelle.
I can talk. Sure.
Yeah.
So again, bringing it back to advanced shared savings, Medicare's investments in the Blueprint for Health programs ended in 2016. So those were the patient-centered medical home, the community health team, and the support and services at home program. The agreement, so the all-payer model ACO agreement, allowed or included provisions for the state and Medicare to continue those funds. And that funding is attached to this Medicare benchmark because it trends forward at the same rate that the board approves, but it does not represent performance risk. And so as Lindsay will show you in the next couple of slides, this advance ends up ultimately being reconciled at settlement.
So this equation here is showing how advanced shared savings gets into the Medicare benchmark and how we reconcile it at the end. So in parentheses represents performance risk, and that should be familiar. It's the equation that we did a few slides ago on how the benchmark is calculated. The advanced shared savings, so that addition of funds on top of performance risk, gets added in at the end for the total benchmark for the year. And so at settlement, at the conclusion of the year, when we want to look at ACO's at the ACO's performance, the first step is subtracting that advanced shared savings back out. So this equation is just re-emphasizing that it's not performance risk, it's just on top. Next slide. Thank you. So OneCare Vermont's Medicare participation to date. So the Vermont Medicare ACO program limits which beneficiaries are included in the financial settlement. So what this chart is showing to the right is the number of Medicare beneficiaries for each year who get prospectively aligned. So at the start of that year, they are indicated to have Medicare versus who ultimately gets included for settlement at the end of the year. So in order to get included for settlement at the end of the year, beneficiaries must maintain eligibility for the entire performance year or until they pass away. And they have to receive 50% or more of their primary care services in the ACO service area. What we're seeing here as the difference between who's prospectively aligned and who's included for settlement grows, this is really from the rate of change in people opting for Medicare Advantage in Vermont, which is growing over time and growing substantially. Next slide, please. So this is just reviewing the settlements to date. I'm going to focus on the 2022 column, but we have numbers from the last 5 years of the agreement. So from 2022, which we just presented on a few weeks ago, actually, the gross savings for us was $20 million. The cap on those savings was $9.5 million. There was a quality adjustment this year. There were some changes which we discussed in the presentation a couple weeks ago, some changes to how the quality scores were calculated. So that resulted in a reduction of $786,000 for that quality adjustment. The ACO's risk arrangement in 2022 was 100%. So the adjustment including the deduction for sequestration, which is part of the agreement, adjusted cap savings is 9.5 million, roughly, and the advanced shared savings that gets subtracted out is 9 million, which netted $490,000 in 2022. Big takeaways from this slide are if you were to sum all of the years in advanced shared savings, we can think about that as money to Vermont providers or to help Vermont providers, in particular Blueprint and SASH. And if you were to sum the net settlement adjusted for advanced shared savings, that's money that the ACO has earned. So for advanced shared savings, it's around $40 million. And for the net settlement adjusted for advanced shared savings to the ACO, it's around $20 million over the 5 years of the model. Next slide, please. So we show this slide every year. This is kind of a high-level picture of where everything landed between the fee-for-service payments, the all-inclusive population-based payment, which together combined is the Medicare ACO's total cost of care, the actual financial target for the year, and then what the difference ended up being. So in 2022, the financial target was about $469 million. The ACO expenditures on behalf of those beneficiaries between AIPBP and fee-for-service is $457 million. So we can think that difference is about $12 million. And you can see kind of how that's changed over time. Next slide, please. Oh, thanks. So, and on this slide, which we also show every year, is the difference between the risk corridor, which is an ACO decision, and the advanced shared savings, and the trend rate, which is the GMCB decision. So we are here to consider and vote on a trend. So on the x-axis, we're showing the different options in trend. So we used a 3.5% trend versus 4.3. And on the y-axis, we have maximum potential savings calculated, maximum potential savings in millions. And we apply the different risk corridors. So 3%, which although it's not finalized, I think is what's currently in the ACO budget. 4%, and then the maximum that they could choose is the 5% risk corridor. And the big takeaway from this slide is there's not much of a difference in the maximum potential savings after the advance between the GMCB's trend rate decision. However, if you look between 3% risk, 4% risk, 5% risk, you can see that there is quite a difference in the maximum potential savings based on the risk corridor, which again is an ACO and their network partner decision. Next slide, please. Okay, so that brings us to the end. So just to reiterate our staff recommendation, we would recommend using the maximum allowable trend for OneCare Vermont Medicare benchmarks. That's 4.3% for ESRD and 6.7% for ESRD. And we're requesting an advanced shared savings of $9,956,390 to fund the Blueprint for Health programs in SASH. And that breakout is about $5.2 million for Blueprint and $4.7 for SASH. Thank you.
Thank you both very
Back
much.
to- yeah.
Mr. Greedy, do you have anything else?
No, I was just going to note that I forgot to put a question slide, so we're all set.
Oh. All right. I will open it up to board member comment or question for the staff.
Can I just pop in with a few quick questions, clarification? So I'm a little bit, I'm trying to understand this difference here. So it sounds like over the life of the all-payer model, we need to be 0.2% below to 0.1% above that national trend. I think you had that in an earlier slide for Medicare, but annually we have to be at least 0.2% below. So how could we ever get to above 0.1% above?
So these are just the target. So I think if we ever didn't meet our goal of that, then it's 0.1 percentage points above national projections for the total Medicare total cost of care per capita growth. I think.
So, so
Michelle?
would that be if we say we ended up doing more fee for service than, because it gets reconciled back to fee for service. So if we provide more fee for service care through the life of the all payer model agreements, that ends up being above 0.1% above the trend, then we would get into trouble with Medicare in this. Is that, everyone's shaking their head nodding? Sorry. Okay.
Yeah, Dave,
Like-
the other thing is the Medicare total cost of care is the entire population.
Okay. All right. Thank you. And then on slide 19, we're attributing this, like I'm looking at 2021 and 2022 with 62,000 prospectively aligned patients in both years, and then 47 and 45. And we're attributing that delta largely due to Medicare Advantage, but it would be, I guess I'm surprised to see the stability in the upper line if a lot of people are adjusting to, are switching to Medicare Advantage. Do we know of other big drivers that are changing the prospectively aligned to included for settlement? And the one question that I had specifically in that is, do we know if people aren't receiving any primary care in a year if they fall out of the settlement included group?
I can take that one, Michelle. So we do have numbers from Lewin, who helps us with this, that break down why that people fall out of prospectively aligned down to included for settlement. It is still the case that the driver is Medicare Advantage, but you're absolutely right that the adjustment for, it's called qualifying and evaluation and management, QEM. That's always a question mark that we have to wait until the end of the year to see what that utilization looks like. In the past, that's also been before Medicare Advantage enrollment or uptake. That was a driver and kind of an unknown until settlement. I think the reason for the stability at the top line is that we don't know if people who are eligible for traditional Medicare will switch to Medicare Advantage during the year. We have some preliminary estimates of what the Medicare Advantage population or enrollment would look like in the beginning of the year, but the last few years, that's been an underestimate, and more people have during the course of the year elected for Medicare Advantage, which for the purposes of financial settlement removes them and all of their, correct me if I'm wrong, Michelle, removes the person, all of their months of eligibility and all of their expenditures completely from financial settlement. Even if they were traditional Medicare enrolled with the ACO, up until that point, all of their experience to date gets removed in what's ultimately included for settlement. But I can get you the breakout from Lewin of the proportion of people who drop out and the reasons after the meeting.
That'd be great. Can I just ask one more
Can I ask a
clarifying
quick question?
Okay.
Oh, sorry. I just want to ask a
Go
quick
ahead.
clarifying question to your question. Lindsay, do we have the 2023 prospectively aligned Medicare beneficiaries number? That might help answer a little bit of Dave's question of why that number hasn't adjusted downward for the uptake of Medicare Advantage. Do we have that number?
I believe so, and I will get it to you.
Thank you. Sorry to
I guess-
interrupt.
The other
No, thanks.
dynamic is that the open enrollment period ends now, right? So when we're running the numbers, the open enrollment period is still open.
So does
And
the
I will add
six?
that Lindsay and I do work every year to do some outreach to Medicare Advantage plans to see if they have estimates. To date, we've not been very successful in getting super up-to-date estimates, so we've relied on what happened in the prior year.
So say for the 62,607 in 22, if someone had a Medicare Advantage plan in 21, would they be included in that 62,000 in 22 or not included in that? In other words, do they reset the fee for service every year and then we set back down? Or do we take last year's experience of who has Medicare Advantage and assume they're going to be in Medicare Advantage this year?
That's a good question, and one which I'll bring to Lewin. They work on the prospectively aligned number with us, so I'll get you that answer.
All right, thank you. And that's all for me. Thanks.
I just wanted to jump in and say thanks to Michelle and Lindsay for the presentation. This is a lot of really complex information and details, and I appreciate your clarity and explaining it all. So thank you.
This is Tom. I'd like to Also, thank you both. I have just a couple questions, mostly about the advanced shared savings and risk. In the earlier slide, I can't remember who was describing the purpose of the advanced shared savings.
You mean the funding to the Blueprint and SASH program?
Mm-hmm. Yeah, do any of the advanced shared savings go to hospitals or primary care providers who care for the beneficiaries covered by the ACO?
The advanced shared savings dollars, as I understand, are a pass-through through OneCare Vermont to SASH and the Blueprint. So in the event that the Blueprint providers would care for attributed patients, then yeah.
Okay, thanks. And then there's a table with the advanced shared savings and the net, this one. And here, the advanced shared savings, the sum across years is roughly 40 million. And that goes to the providers.
That is the funding for the Blueprint and SASH programs, yes.
And then the net settlement adjusted, that goes to the ACO entity itself. Did I hear that correctly? And that's roughly 20 million.
Mm-hmm.
Right. So
Correct.
And
so
the ACO has a shared savings settlement policy that we could review for how that's distributed, but they have a policy that's tied to those savings or losses.
does that mean, Michelle, that the 20 million here does not stay in the ACO entity itself? That it gets distributed out to providers?
There is a shared savings and losses distribution policy. I would have to look into it to see if the ACO does retain any of that. So I will get back to you.
Okay, thanks. Just trying to help understand it. And then the slide with the risk corridors. Yeah. Over the, as far back as either of you can remember or look up, has the risk corridor decided by the ACO changed over the lifetime of the ACO?
Yes.
What can you tell me what's happened with that?
Oh, really testing my history here.
That's okay. I'm not trying to put you on the spot.
No, it's okay.
I'm trying to understand if it has gone, if they've accepted more risk at some point, and then what's happened to their risk tolerance.
Yes, they have accepted higher risk pre-pandemic, and then during the COVID public health emergency, so for 2020, 2021, they lowered that risk corridor. In 2022, I believe it was, it remained at 2% for the 2023 budget. We asked them to increase it, and they did, up to the 3% corridor. So now we're looking at 2024, and what is written in their budget is 3%, but again, that gets elected when they sign their participation agreement with CMMI.
Okay, so the reason why I'm trying to make sure that I'm understanding this is going through my mind. It's obvious from this slide that the decision on risk corridor has the biggest impact on the shared savings that can be achieved at the end of the year. Right. Our decision today about the trend is small compared to the ACO decision about risk. And what appears to me, and anybody please, if I'm wrong about this, it appears that the providers, Blueprint, SASH, with the CPR and the PMH, have received tens of millions of dollars meant to help those entities transform from a fee-for-service model to an alternative payment model, this being one example of an alternative payment. And the thing about alternative payment models is that they place risk on providers, right? But we haven't seen, despite tens of millions of dollars, it doesn't appear as though we've seen a growth in risk tolerance, that the practices, I don't see where evidence here that the practices have been transforming. They've been, seems, using the money to keep running their general business, but it hasn't, we don't see that the risk tolerance has grown. Is that a reasonable interpretation, or am I missing something?
I just want to make one clarification, which is that the Blueprint and SASH programs where the advanced shared savings is funneled to, those are statewide programs that's agnostic of ACO participation in the program. That is just the agreement is the state's mechanism to ensure that those funds still flow from Medicare into those programs. So this is not CPR specific. This is not other ACO initiative specific.
Okay.
If that makes sense.
It does. So thank you. That some of my thinking was a little bit off. I was wrong about that being meant for transformation. That continued a funding stream that existed before the all payer model, and it got rolled into the that helps. Okay, I'm just trying to understand why I understand that the decision about risk is an ACO decision, but it's a partner decision. They have to have agreement with CMS and their providers. But I'm trying to understand why we haven't seen a growth in risk tolerance, because there's so much more available with at the 5% risk corridor. And I'm trying to understand why we're not there yet, all these years in.
I think that's a really good question. I would argue that the public health emergency really probably changed some of that for a little while. And the ACO has since increased 1 percentage point to the extent that they continue to grow. That is, again, a decision between them and their provider network, and then their agreement with CMMI.
That's helpful. I'd just ask a follow-up. Was there real risk during the public health emergency? Or were providers, it's reconciled, and during the public health emergency, was the risk not waived? Again, I'm not an expert about this. I'm trying to understand the.
I think and if I misspeak, someone should correct me, but I think parts of the settlement agreement were waived. So sequestration was not applied in 2020. The quality adjustment, I want to say it was at least only pay for reporting. Yeah, if not like removed entirely. And then we didn't rely, a huge change to how these savings were calculated both in 2020 and 2021 is that we deviated completely from the benchmark methodology that we've actually outlined today. And instead, we waited until the year was up and we did a retrospective benchmark and we said, okay, here's how things actually shook out. Let's look back at that trend and see, you know, let's set the benchmark with that and then see where the ACO came in. So also a totally different calculation methodology. So, but in terms of your question about risk, like was there actual risk? Not sure I know how to totally answer that. But
Okay.
I think
Yeah, I think
we could bring that back to like Lewin and discuss with them.
I would also,
can
I
bring
did
that back.
ask the ACO that question in the budget hearing, so we could pull from the transcript. I did ask them why we weren't seeing hospital risk tolerance bounce back. And I don't want to misspeak, so I think it'd be better to pull it from the transcript.
Okay.
Yeah, and I think, Tom, we could show you, Lindsay and I can walk through a more detailed financial analysis with you if you're interested, but there were, Lindsay said sequestration didn't occur. There were changes for how reconciliation occurred for things like COVID-related claims at the time, which were kind of unknown, right? Like how much that would have an impact. And so there are other changes that occurred in those years that we could certainly walk through with you if that's of interest. But I just wanted to flag there were some other underlying things that in the claims space were adjusted for.
Yeah. Well, I think, at the start of the public health emergency, everybody was terrified. And so I think my understanding is that steps were taken at the beginning, knowing that we were facing uncharted territory to minimize risk for providers and healthcare systems. And I guess I'd be most interested if in seeing the response to Robin's question when she asked why we haven't seen the risk tolerance jump back and actually go further as we've gotten further along with the model. Seems like she asked that question a while ago, and maybe I just need to listen to that again.
I will look for it in the transcript and try to pull that out.
Thank you very much.
Michelle, I was wondering if you wouldn't mind going back to the risk corridor versus advanced shared savings slide. Thanks. One thing that I just wanted to call out, although I do think it's a good idea to go back and listen to the transcripts, is that this is right here we're showing the maximum potential savings, but this is a two-sided risk model, which is pretty rare, I think, for ACOs nationwide. So we're not showing the maximum potential losses here. And I admittedly don't know, and it would be worthwhile going back to look at the transcripts or look at hospital budgets and see how many hospitals in the ACO network are poised for the maximum potential losses, although that scenario is very, well, I don't want to make any judgment about that, but I'll just say like it is a two-sided risk model. And so understanding about hospitals' ability to like fully assume that risk might shed some light in addition to the ACO's comments from the last conversation.
That's a really great point, Lindsay, really smart, and I appreciate you bringing it up. So I wonder, over the life of the ACO, when have providers faced a loss? Like, when would they have had to pay back in the way that you're describing? those are losses from the quality, right? I understand, but the two-sided risk that we're talking about with that chart would be if an organization went over the budget target.
We could
Yeah,
certainly look into that for you. I think that's probably a really great question for the ACO team who's going to present to you
Okay.
next.
Yeah.
Well,
But we could certainly look into it for you.
Yeah,
Yeah.
thanks. This is my second or third time seeing this, and you guys you do a great job walking through it. It's confusing. I still feel like I don't know enough, and thanks for answering my questions.
I'll do my best to pull these maybe at our lunch break, and get them back to you just so you have sort of documentation.
All right, that's amazing. Thank you.
Any other board member questions or comments? I just have one. If you go to slide 13. So the trend is based on national projected growth for Medicare fee for service. So Vermont just needs to be no worse than 0.2 below that trend line, right? So if Vermont is typically a affordable or low cost Medicare state and is historically growing less than national, there's an advantage to us to hit the total cost of care targets. Is that fair?
I think that's fair, but Lindsay.
Yeah, that is fair. I just one point of clarification. Before the all-payer model, our I always kind of muddle this up, so I'm going to try to be really clear. Our growth actually outpaced national, but our per beneficiary per year dollar amount was way below national. And after I'm going to say after 2017, which was a startup year, call it 2018, is when our growth year over year slowed to be more like nationals, and our per beneficiary per year Medicare payments are still way below national. Yeah, but
Got it.
but in general, you're right. Yes, we have
Right.
an advantage there. Yeah.
So we were growing faster than national, even though we were well below national in the absolute dollar amount. And then now we are growing less than national and our absolute dollar amounts even lower comparatively. Got it. I didn't have any other questions, but thank you. This is really helpful. I'll open it up to the healthcare advocate and to any public comment after. Good morning, Mr. Fisher.
Good morning, Green Mountain Care Board. Just coming on briefly to remind everybody that we submitted a written comment on this, and stand by that comment and have no further comments to make at this time. Thank you for your work.
Thank you. Any public comment? Great. Well, Ms. Kill and Mr. Gree, thank you very much for your presentation. And we can, why don't we take just a 3-minute break and then we'll come back for the ACO presentation just so we can switch over. So we'll come back at 10:12. Thank you.
Can I get a sound check? Sound okay?
Sounds great. Is Member Walsh back? Great. Okay, we can resume our hearing, and Ms. Melamed, our Health Policy Project Director, and our Staff Attorney Russ McCracken will present One Care Vermont's fiscal year budget deliberation and presentation.
Great, thank you, Chair Foster. I also will be joined by Elena Barabee, Director of Health System Finance, for some of these. We are filling in for Michelle Sawyer, who couldn't be here today. So thanks to the team for coming together to pull this presentation together. So again, my name is Marissa Melamed, Associate Director of Health Systems Policy, and I'm going to pick up the discussion and presentation from last week on the ACO FY24 budget and discuss budget modification and approval options today. There is no vote noticed for today, so it's a continuation of the discussion. All right, so the Green Mountain Care Board staff developed budget modification options based on board discussion and ACO standards of review. The options were refined from last week based on the following principles that were gleaned from the discussion so far. One, that the One Care Vermont budget and programs need to generate more value for Vermonters and more value for the network of providers. And two, that the One Care Vermont budget and programs need to increase support, resources, and incentives for primary care. These are things that we've heard from the discussion so far. For the purposes of this review, we're defining value as supporting requirements in Rule 5, specifically Section 5.403, particularly around supporting population health, such as, so here are examples from the rule, providing incentives for systemic healthcare investments to strengthen primary care, including strategies for recruiting additional primary care providers, providing resources to expand capacity in existing primary care practices, and reducing the administrative burden of reporting requirements for providers, providing incentives for systemic integration of community-based providers in its care model, or investments to expand capacity in existing community-based providers, as well as providing incentives for systemic healthcare investments in social determinants of health, such as developing support capacities that prevent hospital admissions and readmissions, reduce length of hospital stays, improve population health outcomes, reward healthy lifestyle choices, and improve the solvency of and address the financial risk to community-based providers that are participating providers of an accountable care organization. And finally, providing incentives for preventing and addressing the impacts of adverse childhood experiences and other traumas. So these are specific population health review criteria from Rule 5. And as well, we are going to look at, so another, sort of measure of value here that we've been looking at in this budget and over time is declining attributed lives to the ACO, while the budget has stayed relatively stable. That is the operating budget. No substantial or insubstantial evidence for impact on quality, access, and affordability that are measurable for consumers. It is still unclear how hospital primary care is being allocated to hospital primary care practices, as well as we've been looking at evidence that well-funded primary care and community-based providers, specifically through medical homes, improves outcomes. So looking to support the resources and incentives for primary care has been a priority from the board and through board discussion. So Based on those principles, we have several options for your consideration. So the first one is that, yes, the ACO has met its burden of proof for its submitted FY24 budget. And in that case, the board may vote to approve OneCare's budget as submitted with any or all reporting conditions. Those reporting conditions were presented last week, and they will be, they can be refined if needed and posted again for the vote. So for example, for one, if you feel that the ACO has met, or sorry, if the decision is that the ACO has met the budget targets that were set out in the guidance to board member satisfaction, or if not met, those targets were sufficiently addressed and discussed, you may decide to approve as submitted. If you do not feel that the ACO has met its burden of proof, we have, and I'm going to continue to lay out 3 options for modification. The first one is options around modifying the operating budget. You may choose to, or the reason to do this would be to reduce healthcare dollars that go toward expenses OneCare has not established are necessary for financial and quality improvements or patient care. You may choose to modify the risk model as presented in the FY24 budget. And the reason for this would be to increase earning potential and incentivize high performance. And this was discussed in the previous presentation. Also, on the flip side, this does increase risk for poor performance on the downside. Within modifying the risk model, you could also choose to delegate or make a modification to the risk delegation. Currently, the risk is delegated mostly to the network hospitals, with some risk held centrally at the OneCare ACO level. There were budget targets in the guidance around increasing the amount of risk that's held centrally at the ACO level. Those budget targets were discussed during the hearings and not met. So we want to revisit that. And the reason for doing this, well, there's a couple that were discussed last week around providing sort of a glide path for participation for hospitals with thin margins where it may be difficult to take on risk. Another reason for doing that is to increase accountability at the ACO level. So have the ACO hold some of that risk centrally to hold some of the sort of accountability for the programs that are being pushed to and supported for the network. The third option, and we're going to discuss these a little bit more as we go through the slides. The third option is around modifying investment in population health management or primary care. So if more value is generated through either reducing the operating budget and freeing up that revenue, that revenue could either go back to the hospitals and in the form of decreased hospital dues, or it could be reallocated to investments in primary care or population health in the current budget year. Or if you were to increase potential value through modifications of the risk model, those dollars or potential dollars, if there are shared savings, would show up in future years, but would not be available for this budget year. And reasons for modifying investments in population health and primary care would be if you find that there's insufficient support for primary care and population health in the current budget as submitted. So now we're going to walk you through these options a little bit more. I had help from the finance team on the options to modify the operating budget. So if Elena, you're on, I want to talk through that slide.
Sure.
That
Can you hear
me?
Okay.
Yes, thank you.
Great. So these are options for reducing the operating budget. What we did to make sure that we were kind of thinking of the budget in a holistic way and not coming up with line item suggestions was to think about, the operating budget with respect to return on investment. So thinking about the number of lives that this operating budget would be supporting in terms of the programs that that OneCare is implementing. So we came up with kind of 5 different ways based on the operating expense to attributed lives ratio. The first ratio is taken as given in the FY24 budget as option 1. Option 2 takes a 5-year average across all of the from fiscal year 19 to 23 projected. And that brings us to about, $900,000, so a reduction of 6.2% to OneCare's operating budget. Or you could take an average of the current fiscal year and the 23 projected fiscal year. That would get us to about $81 or almost $82 per attributed life. So it's a reduction of about 8%. If you hold FY23 projected flat to FY24, this would be a reduction of about 16%. And then if you take the amount associated with the highest scale year, that means they were serving the most number of attributed lives, that would be a reduction of about $4 million or about 28.5%. So it'd be quite substantial as a proportion of their budget. And you can kind of see visually the reductions. It's just the graph on the right is just plotting kind of where it's been historically and what that kind of change would do to the budget. Any questions before I pass it back to Marissa? Happy to answer at the end too, if that's better.
One quick one. These are all adjusted for inflation, so that
Yes.
But the chart on the right is not, right? That looks like nominal.
Yeah, I think the chart, Matt will have to answer that question if he's on, but I believe.
That's correct. So the ratio is adjusted for inflation, but the budget impact and the graph on the right are nominal. So so you can read that as like negative $892,000 would be the nominal cut to their submitted budget.
Thank you.
Great. Back to you, Marissa.
Okay, and we can come back for questions on all of this as we get to the end. Okay, so the next slide, I'm going to lay out some options for you to modify the Medicare risk model. So there was a budget target. There were 2 budget targets that were discussed during guidance development around increasing the Medicare risk corridors, as well as having the ACO hold, the way it was in the guidance was the equivalent of the Medicare advanced shared savings amount, holding that centrally at the ACO level, as opposed to delegating all that risk out to the network. Though neither of those budget targets were met, and that was described and explained during the hearing, that the ACO took that guidance, through their board of managers and budget development process, and decided that that did not fit their model or their sort of philosophy for their risk model. So there's quite a bit of discussion about that. So again, those budget targets in the guidance are not binding. They're guidance that the board set forth based on things that we wanted to see from last year's budget review, and wanted to give those in advance to the ACO so that they could bring them through that budget development process and work toward those. Those were not met, so we're bringing that to this process to see to see where we're at in terms of making modifications here, or whether the the rationale for not increasing the risk in this way, if that explanation feels sufficient to board members. So here are the options. The Medicare risk corridors in the budget as submitted are set at 3%. Could you, as the board, require the ACO to increase the risk corridor from 3% to 4%, and what would sort of the impact of that be? The value of that 1% increase is about $6.7 million. We have a calculation that we'll show you there. And then there was in the slides that Lindsay and Michelle went over previously, they also have a slide that shows sort of what that difference is if you go from the 3% to the 4% or even the 5%. They're roughly equivalent, but they're calculated slightly differently. We calculated this $6.7 million number based solely on OneCare budget submission. So it's approximate, but it's approximately $6.7 million of additional upside and downside risk if you were to increase the risk corridor by 1%. So the reasons for doing this would be, again, to increase upside and downside risk potential. It would increase the value that can be earned from the cost of operating the ACO. It would increase the potential shared savings that could be earned through the Medicare program. It does require agreement from the network participants to participate in the Medicare program. So yeah, it would take sort of still that two-side negotiation. And if the network participants don't want to participate, then it puts that Medicare agreement in jeopardy. So that is a real risk as well. The other option is that the ACO could hold all or a greater portion of the Medicare risk, and it's a potential risk mitigation option for increasing the risk corridor. So on that, in the first column there, the ACO to hold all or greater portion of the Medicare risk. So as submitted in the budget, there is the ACO centrally is holding about $1.8 million in risk, and that is a provider sort of risk mitigation strategy for one hospital. The guidance set out that OneCare should hold all of the Medicare Advanced Shared Savings risk, which they did not do in their submitted budget. And the value of that is about $9.95 million, plus the existing provider-specific risk mitigation. So it'd be a little over $10 million of risk that the ACO would be holding on its books if it were to do what the board said in the guidance. The alternative approach that we are presenting today is that OneCare could hold the additional 1% of Medicare. So if they were to raise the risk corridor from 3% to 4%, could the ACO hold that risk amount centrally? Again, the value we calculated about $6.7 million. And the reason to do that would that it can potentially support hospital participation in the model. If the reasons for hospitals not wanting to participate at the higher risk levels because it's too much risk for them, does the ACO have the capacity to hold that risk so that we could still potentially, glean that value without the hospitals having to take on additional risk and having the ACO back that. It potentially increases accountability at the ACO level. So the ACO as a central organization providing resources and supports to hospitals, it sort of holds them accountable for a certain amount of risk. So it potentially increases incentive to make sure that those programs and supports are effective for the network. And again, just a reminder that this was a budget target that wasn't met. So is there sort of an alternative? If the original guidance is a bit deep at over 10 million, is there potentially an alternative which could also produce some additional value? So the next slide just kind of goes through the math on this so that you can take a look at the sort of submitted total cost of care at the 3% risk corridor. The ACO budget calculates that max downside risk at about $17.2 million. OneCare is currently holding just a little under $1 million of that for one hospital. And the rest is all delegated out to the network. If you were to increase that risk corridor to 4%, then you you can see the change there. And I'm seeing, sorry, the 6.7 million that we have on the previous slide is the difference in the downside risk plus the risk that OneCare is also holding for that one hospital. So that's how you get up to the 6.7 that potentially could be on their books. And then the table below just sort of lays out how much it would be if OneCare held all the Medicare Advanced Shared Savings risk at the OneCare level, which was in the guidance. And if we have more questions on this math a little bit later, Matt can probably help with that. We can come back to the questions. Again, just another way to look at this visually over time. The orange is the provider held risk that has been delegated out to the network, and the blue is the OneCare held downside risk. So I think there were questions earlier about, how the risk levels dropped off. The 2020 is the pre-COVID budget, so OneCare was working toward much higher risk levels. They still had that kind of just about $4 million worth of risk that they were holding. And I know that the ACO has talked about over time moving toward delegating all that risk out to the network. And we've been having discussions about how much or whether or not it's appropriate for them to hold more centrally. So the 21-22 budgets had practically no risk. I think the original 23 budget had practically no risk held at the OneCare level. This amount in the revised is because the board ordered the ACO to hold about half of the Medicare Advanced Shared Savings risk in the budget last year. And then the board required it again in the guidance, or set it out as guidance for 24, but the ACO declined to do that. So it went back down to just that risk mitigation for the one hospital. So it's under discussion for today, how much risk is appropriate to be held at the OneCare level versus to be delegated out. One more look at this, just numbers over time so that people have them. That's the total cost of care budgeted amount over time, the total risk over time, and then how much has been held at the provider level versus the OneCare level. So this is just the numbers behind the bar chart previously. But another data point here that is important is the net assets or equity that OneCare holds. And this is important because if they're going to hold risk, they need to have a risk mitigation plan about how they would cover those losses. There's really specific requirements in the Medicare agreement about covering Medicare risk. So the board would have to consider risk mitigation, and the ACO would have to have a risk mitigation plan if they're going to hold more risk. But to illustrate, the bottom line here shows net assets and equity. So at the $6.7 million level of risk, it does appear that they would have assets to cover that currently, but not at the higher level that was set in guidance at the over $10 million level. There's also a line of credit that's required under the Medicare agreement as part of the Medicare risk mitigation plan for Medicare losses. Okay, so this slide moves us on to the options to increase support of primary care. So if the board chooses to cut the operating budget, and then there are dollars from that in the total budget, how might they be reallocated, which was something that the board chose to do last year. So there's 5 options. And these options are laid out to be applicable to all primary care, not just independent. There's been some discussion, including the HCA comments around specifically directing reallocation of dollars to certain providers. This is laid out to be all primary care providers who are participating. It's worth noting that the issue of being able to track dollars through hospitals down to their primary care practices has not been resolved yet. So Again, the board could choose to reallocate these dollars. There are some questions that came up last year about how those dollars actually make their way to primary care providers, to hospital primary care providers, and that remains unresolved. The first three options involve different ways to add money to the population health management program. It's also worth noting that in their submission, OneCare wrote that if additional resources were available, they would invest them in the population health management and CPR programs. So the question was asked to them, you know, where would you put money if money was available? So we wanted to take that into consideration. So the first three options, you could increase the population health management bonus payments. Of all the population health management options, this is the increase in overall earning potential, and it's linked to performance. So if it goes in the bonus, then the providers have to meet certain requirements and perform in order to earn that dollar. So there's also the potential that it wouldn't be earned, and it could be deferred payment or reinvested, but it potentially increases incentives for high performing practices. You could also choose to increase the population health management base payment. This is guaranteed increased funding to primary care providers who are participating. You could also choose to split the additional amount between population health management base and bonus payments. And again, so you have the two kind of the benefits from both there, potentially a little bit more complicated. There's also the option to increase the mental health screening and follow-up initiative payments. However, considerations here, OneCare has not yet shared the program details for what the FY24 iteration of this program will entail. Putting funds here would not provide a clear outcome of how funds would flow to providers. It is currently budgeted at $1.67 million. The other option just to consider, or that has been floated, is if we increase the risk corridor from 3 to 4%, you could potentially say that you want any shared savings on that increased amount to go specifically to primary care. So I think, again, as came up in the conversation this morning, OneCare does have a settlement policy for how the shared savings and losses are distributed or delegated back to the network. And I did a quick scan of that. You know, as the providers hold almost all of the risk, they also get back all of the potential savings or cover the losses. For the small amount that OneCare is holding centrally, that you know, can be determined at settlement. So if OneCare was going to hold more of the risk centrally, they would have to update that settlement policy to you know, show or decide how any earnings would be either delegated back to participants, maybe primary care specifically, or how it might be reinvested in ACO programs. This slide, I'm bringing it back from last week that Michelle presented. This slide outlines how OneCare has offered support for primary care practices outside of fixed prospective payments. And so over the years, this has been done through the Complex Care Coordination Program, the Value-Based Incentive Program, Primary Prevention Initiatives, the current PHM program, the CPR Comprehensive Payment Reform Program for independent providers, and the Mental Health Screening and Follow-Up Initiatives. These dollars are linked to attribution. So the overall amounts have decreased as attribution has fallen, but that as a per member, as a per life amount, it's increased. So the overall amount that's available, because there's less providers and less people attributed to ACO programs, has decreased, but the amount that individual providers can earn per life has increased. So for providers who are still in, potentially they can get more per life, but less is going to the network because less people are attributed. The next slide, again, I can't remember if this was in last week, but we brought it back just to talk about the amount of primary care spend, or the percent of primary care spend in Vermont, and that there's been a lot of discussion around how to increase that. So this is based on 2019 data from the PCCC report, which shows that the percent of primary care spending as a share of total healthcare spending. The report, there's a couple important notes here. The report doesn't include fixed prospective payments or non-claims payments, so there's no blueprint in here. But in this report, Vermont is ranked the 7th lowest in the nation for primary care spend, with the narrow definition and 19th lowest with the broader definition of primary care spend. And there's been, discussion around, evidence of how well-funded primary care improves health outcomes for Vermonters. And is less expensive than hospital care. This is generally associated with medical homes and other, specific primary care programs. So there's, I think, a general understanding that there's room for improvement in Vermont in terms of spending on primary care. And so, this is an area I know that's been of interest to the board in terms of dollars that could be reallocated. Okay, so just a summary of options, and then we have a couple of appendix slides that could help with questions and discussion. So again, the decisions are approve the budget as submitted or make modifications. We are laying out options for you to reduce the operating budget. This could have no reallocation, or it can have an allocation to primary care and or population health. And there's also the option to increase the Medicare risk corridor. And this would be funded, so to speak, or backed with existing reserves. I think I'll just click through these appendix slides, and then I can turn it back to you, Mr. Chair. But this is the spending per life that was presented last week. Matt Sutter, our wonderful financial analyst, did some comparisons to the HCA analysis, which there's questions on that, as well as this visual, which was some modifications that we made to the per member ratios here, just to give you some general, just sort of a visual on what's happening over time with the operating expenses ratios and the population health management attributed life ratios. On the left side, payroll and professional services and operating expenses have been relatively stable over time, even with fluctuating attribution. Population health management and attributed life ratios have declined, but I think it's really important on the right-hand side to kind of think about the effects of the pandemic and those, in those years. Those investments necessarily had to drop off. So if you took a subset of that, chart on the right, from 21 or even 22 forward, the line doesn't quite look as steep. So you kind of have to think about it in the full context and kind of universe of what's happened over time. But hopefully these are helpful to sort of reconcile the way we did the original and the way the HCA did it, for your consideration. And Matt, I see you popped on if you want to say a couple things here, or we can just wait for questions.
Yeah. Marissa, could you go back to the preceding slide?
Yep.
I think it would be helpful. I'm realizing now my labels are incredibly confusing. So if I could just go through really quickly and explain what each of these tables represents, I think that'll be helpful for everyone. So the top table is as we presented last week, and it's the same table as on the slide before this, just in a slightly different format. So that includes blueprint dollars. It's in nominal, non-adjusted dollars using average attribution and actual projected for FY18 to 23 The table directly below that is the exact same thing, just with inflation adjusted dollars. The table below that is excluding Blueprint. So this was me trying to recreate sort of the HCA methodology using a different attribution figures and the actual, and more importantly, the actual and projected amounts for 2018 to 23. And then the table below that that's labeled simply budget, and I apologize for that. That's very confusing. But that was my recreation or attempt to recreate the HCA's, recreate this table using the HCA's methodology. So you'll see that the attributed lives are very different for that one, and that's using. I think Eric might have to speak more to the methodology there, but I just wanted to use his attribution and the budget figures that we were carrying in our database for these. So I apologize again. The actuals and budget, I'm realizing are not like the most helpful labels for these, but that's what that's mostly referring to is the historical years and what we're using for dollars there.
Thanks, Matt. So I think that the sort of takeaway here, because I think some of the modifications are based on this kind of analysis, is it appears that the operating budget has been held relatively stable, even if you adjust for inflation, despite lots of fluctuations in attribution, participation, effects of the pandemic. And if you look over, the span since, I guess it starts at, I think it is goes back to 2018, that the ratios for population health management and attributed life are declining. Again, you have to factor in effects of the pandemic here as well. But it brings us back to the original question around, does the board feel that we are getting the value out of that operating budget? You may decide that the operating budget is appropriate to the size and scope of an ACO of OneCare's size and their model. Could they be getting more value out of that operating budget? And that's sort of the questions that we have before you to discuss. So I will turn it back to you, Chair Foster, for board questions. I can keep the slides up if they're helpful, or I can take them down for discussion.
Thank you. That was a really excellent presentation and really helpful walkthrough. So that was great. I really appreciate that. I think just to frame any discussion or deliberation, it might be helpful if you put up the slide with the various options just to kind of focus the board.
Okay, I'm gonna just do a different view here real quick to make sure that I can still see faces. Just give me a second. Okay, I think. Is that working?
We can see it. It's on slide 6 right now.
Yep. I go back to the options. This the one you want?
I think that's probably the best outline of it. Yeah. Yeah. Okay, thank you. I'll open it up to the board members for any thoughts or questions they may have.
I guess I can jump in if nobody's popping off of mute. Thank you, Marissa, and team for the presentation, and Michelle for the work that went into it to hear. Just first off, I really appreciate your discussion of the term value. I think this is such like a crux term in the whole world of value-based anything. And so I think sometimes we have different definitions of that term, and we assume others share that definition. So I appreciate the specificity there. I have a few questions that came up through the presentation that I want to just address first. One is actually from the Medicare benchmark presentation as it relates to OneCare and the recent return on investment report that OneCare provided to the board, which I know we haven't had time to fully digest. But I don't know, Marissa, if you or the team can help me understand the figures that were in slide 20 of the last presentation, which we've shown previously, and it may actually be in this presentation. I'm sorry if I didn't write that slide down. It's the grid with all the sort of potential shared savings, the actual earned shared savings, the risk adjustments for those shared savings, the blueprint money, and the actual paid out shared savings. So it doesn't include the administrative expenses like the table does in the ROI submission, but it has very different figures for the shared savings. And I was just curious if you've had a chance to look at those and you can reconcile the difference of those numbers at all.
I have not. I'm not sure if Michelle Degree or Lindsay can speak to that. But I know that, so sometimes we get different numbers based on numbers that are in the ACO budget submission versus how Lewin calculates it. But no, I haven't looked at that or been able to look at that specifically.
Okay. I guess the next section goes into of questions that I have is really related to slide 5. So we could probably move to slide 5 if that's possible. And this really kind of relates to some of the concepts of risk and incentives. I think one of the challenges that I've learned, that I've developed with understanding OneCare's capability to transform care in our Vermont ecosystem is its relationship to incentives and how all that works. And I think that actually seeing these recent presentations by some other ACOs, which have more traditional ACO related incentive pathways, seem a little bit more straightforward, where the ACO holds the risk. The ACO then is incentivized to try to reduce overall healthcare spending, and the primary care practice is incentivized to essentially try to shift healthcare spending to primary care because it's less expensive. And so the net result is the ACO makes money when healthcare spending goes down, and the primary care practices make money when they can get people in more to be seen and reduce overall spending. Where OneCare has a different arrangement where they, as an organization, don't seem to have an inherent incentive system within OneCare to generate savings beyond that of the hospital dues, which are returned to the hospitals. There's no inherent incentive system within OneCare to save money because, well, it's a nonprofit versus a for-profit, and we can have a longer discussion about that, but there's no, as far as I know, incentive strict system within compensation that would lead to them wanting to generate large amounts of savings, nor are the primary care providers, or at least to a large degree, the primary care providers within the OneCare network aren't incentivized similarly. So with that background, I was looking at the slide and I had a few questions on it. And one is, when we look at the potential for downside risk, and we recently had a discussion within the hospital budget process of case mix index and coding. If Vermont hospitals were to optimize their coding and capture all the medical complexity of the patients that they're seeing who are Medicare patients and generated, would that change our benchmark? Or would that just change, it would increase the fee-for-service reconciliation, the overall billing, but would it lift the benchmark because the patients appear more, are being documented in a way that they would look more complex? Or does that increase their exposure to overshooting the target? Is that too complex?
No, I
Poorly worded
understand the question. I don't think I can answer it because I would need somebody who has a little bit more familiarity with how the benchmark base is calculated. So I cannot answer that question. If somebody on the line can, otherwise we can get back to you. I don't know, like, I don't know what that would do to the benchmark.
Marissa, I have to apologize that I missed like 90% of that because my audio suddenly went very
off. No problem. You didn't miss much because I said I don't know. I don't know
Okay.
well enough. I don't know what that would do to the benchmark calculation.
Okay.
I mean, it's a base, so it wouldn't do anything immediately. You know, calculate off of a base, but I don't want to misspeak on that.
So the
'cause I'm not
benchmark
very familiar with
base-
that calculation.
So with the benchmark, so as far as you're aware, or maybe if anyone else knows could chime in, is the benchmark base a dollar amount? And if if the experience of the patients in Vermont in a given year show that there's more medical complexity, would that change the dollar amount or no?
So maybe I can jump in. So the base is calculated by Medicare's consultant. It's not something which our staff is responsible for. So Lewin, who was referred to earlier, is Medicare's consultant. So I'm not sure if we have that level of insight into the algorithm.
Okay.
So I don't know the answer. I don't know, for example, how I'm assuming there's a data lag. So the base they're calculating on, you know, Lindsay mentioned that a little bit, that it's 2023, but there's an update factor. So I think it's a hard question to answer for our
Okay.
staff because we don't actually do it.
Yeah, and it's not something I thought of prior to the presentation. Oh, Michelle, do you have a thought on it?
Sorry, I'm double muted, so had a hard time coming off there. Robin is correct. So Lewin runs that analysis for CMMI. In the calculations, we work with Lewin, and Lewin also works with the ACO to do their best to use the most recent data available so that the projection time period is as small as possible. But Robin is correct that it's never going to be a full year of experience that's building into that next year's like a complete experience. It's this year
It's still a
did it,
retrospective.
a full 2 quarters.
Yeah, it's still retrospective to the prior experience as far as however they calculate that benchmark. Is that fair to say? Okay. And then as you were explaining this, Marissa, I was sort of writing down a question that I think you were answering as I was writing it down. But I want to sort of make sure I understand this correctly. So say theoretically, OneCare held all the shared savings risk. Say theoretically, the roughly $10 million of risk. And the risk corridor was increased to 4% from 3%. That the overall risk taken by the hospitals actually stays the same or maybe adjusts down slightly, somewhere in that neighborhood. It doesn't expose the hospitals to any more. It probably actually exposes the hospitals to a little bit less downside risk, at least looking at the graph, at least looking at the figure from the last presentation for the Medicare benchmark rate, which had had the difference between a 3% and 4% of about $7 million, I think. So is that fair to say? So if OneCare held more risk, hospitals would experience the same or less risk with significantly more potential benefit.
Yeah, we didn't do that calculation, I don't think exactly. If the ACO were to hold the $10 million in advanced shared savings, then that would take, I mean, you can see it in one of our tables probably. I just don't have the calculation done. It's 5.1 in that workbook. Then that Medicare advanced shared savings risk would come out of the hospital's risk levels. And then, yes, you could potentially increase, or OneCare could increase the risk corridor. But again, that additional risk, which is like another $6.7 million, would also have to be either allocated to OneCare or to the hospitals. And so then you start to get, you know, up to amounts that are definitely well over the ACO's reserves.
Okay.
So yeah, we didn't actually do a calculation of that particular option. If they were to take all the advanced shared savings risk and bump up the risk corridor, what would that look like for the hospitals?
Can you go to slide 10 for a different question? So this amount per life is, I just want to make sure I understand this calculation correctly. So this is the 154,655 lives, $12 million divided by that 154,655 lives. Is that correct? Gets to $83.
Yes,
the amount
so it's an amount,
life.
yeah, per life.
Okay. And that is,
this one is unadjusted too.
okay, and that is a combined Medicaid, Medicare, and a small amount of commercial that's in there at this point.
Yes, and this is the average attribution. So the amount that OneCare uses for budgeting purposes, you know, because as you know, the attribution drops off over the year. So
okay,
kind of
I
a
was just trying to
made up number that's an average, yeah.
Okay, and that is the amount that is paid out on average, the average of the average, to hospital-owned, independent, and FQHCs for all of the various programs, the non-blueprint programs, so CPR, DBIF, mental health screening, population health management, primary prevention programs.
Yes, there's kind of suite of population health management programs. That's the total that's available, and then the amount, yeah, per life.
And now that we have,
and it doesn't necessarily mean that they would earn all of it, because you know, it's the base and the bonus.
Okay. And now that we have a little bit of a point of comparison from the Vitalize budget, which had 2,005 lives with $754,000, which is much smaller, very small, as only Medicare lives, but that ended up being like $370 something per life is my sort of quick estimate on that. I'm just trying to understand the magnitude of differences of what's available to these primary care practices through these different arrangements. It's not apples to apples by any means. They're very different programs.
Yeah, yeah. I didn't do that calculation, but I know that question has been raised. How does this look? You know, again, it's not apples to apples comparing the Medicare only programs to OneCare. They're very different ACO models, but yes, several people have asked, well, what does it look like compared to being in one of these programs? But it's a relevant question because of, you know, like FQHC participation in you know, OneCare or one of these other models. So it is sort of interesting to compare how that might look, you know, to think about how how it might feel for an FQHC to kind of look at these different models and see what might work well for them. Because my understanding is that OneCare is trying to develop an FQHC like FPP model as well. So it's not apples to apples, but it is an interesting comparison.
would you just, do you know much about, I know you were deep into the OneCare budget last year, and that the interest in developing a FQHC FPP model, I believe, was discussed last year. Do you know if that extends to years prior?
I know it's been talked about for several years in a row. Since I'm kind of pinch hitting here, I'm not sure I could speak to you in great detail about what, how that's sort of evolved. I can try to pull it up, but I know it's been in discussion for several years to try to develop an FPP or fixed perspective payment model for FQHCs. But I'd have to look up kind of what that looks like in the FY24 budget, unless somebody has it in their head who's on the phone.
My recollection is that there was going to be some work on the FPP for FQHCs, but that it wasn't clear if that would be implementable this year. That's my recollection, which could be off.
Thanks. Well, if you want to go back to the slide discussing the options, I think part of my challenge with OneCare is trying to understand where OneCare sits within Vermont's health reform, ACO, health transformation landscape now, as compared to what it was previously. And I think that's part of the challenge of looking at some of these trends over time, is that the role of OneCare, I think, has migrated and changed somewhat over the years. Granted, I wasn't here prior to last year and looking at this in great detail until last year, but the early years of OneCare within the all-payer model seem to be focused on participation attribution, and as for various reasons, many not related to OneCare at all, that did not materialize. So here we are sitting in a different place where, a large statewide attribution to a single ACO with attribution goals that are high enough to hit the theoretical thresholds to lead to like a broad transformation of how healthcare payments are provided, leading to care transformation and how healthcare is delivered, I don't think are going to work within this this model. And I don't think that's a stretch to say that. If people feel differently, I'd be really interested in that conversation. But at least as far as I can tell, even in the scenario that Blue Cross Blue Shield somehow rejoins OneCare, and even in the scenario that was done in a non-reconciled fee-for-service way, we would still not hit the attribution goals that would be needed to do what the all-payer model had intended to do in the beginning, which was to improve, lead to this transformation for fixed perspective payments, improve primary care, cost containment. So I'm trying to think about how to think about OneCare in its current state and our current state of where we are in this reform effort. And so that's just sort of my broad perspective on looking at where OneCare is. I think, as I discussed, I think that there's challenges that are structural in relationship to the incentive system and structure of incentives that OneCare kind of, again, is nestled in, that are, neither, the hardworking employees at OneCare who I'm sure, I don't know many of them, but I am sure they're like many of the rest, almost all of the rest of the healthcare community of Vermont are super dedicated to trying to improve healthcare for Vermonters and lower cost of care and provide appropriate care and great care. They, they didn't build the incentive system that they're sitting in. So I think that's sort of a challenge on how to evaluate the potential for the sort of transformative work. I really, the stories that we hear from providers regarding the successes of the CPR program are very supportive of that program, and probably the most supportive of any of the programs of OneCare. And it's not surprising that's the case, because I think if you look at the broad landscape of ACOs across the country and where they're successful, it's in that group of people, the independent providers and FQHCs that are empowered to really transform the delivery of primary care, and can have incentive structures that are really supportive of them to do that. So I think anything that we can do to help support OneCare to expand and improve those programs is probably one of the areas of greatest benefit that OneCare can have in its current sort of seat within the healthcare landscape. When I get to the question of has OneCare met its burden of proof to justify their administrative budget, I don't see that they have met the burden of proof to justify their administrative budget. It was described as a bottom-up budget, but it wasn't created in a programmatic way so we could evaluate the investments in various programs or the return on investments of these various programs to understand the cost effectiveness of programs. We'd asked for that. My understanding is they said they don't do it that way. We don't have information on executive compensation and their specific and measurable benchmarks, specific and measurable incentives that are used to improve value and cost containment and quality of care. And we don't have executive compensation benchmarks, which, to OneCare's credit in this budget, they've sort of retracted from the idea that their executives have benchmark salaries and that many of the salaries are determined from prior years. But still, it's very hard to evaluate that component of their administrative budget as well. So I guess that's where I stand. I don't have a defined opinion on a specific plan. I struggle with the structure of incentives and its relationship to risk somewhat, but I think that's an area of potential performance improvement. So I think I'll leave it there, and thank you so much for taking my questions, and the whole team for working together to understand this and present this.
Any other board member questions or comments?
I see Tom off mute, so I'm waiting to see if he's going to jump in, so I don't interrupt him, but I can go next if not. Okay. Marissa, could you go to slide 8, please? Thank you. So one of the things that would be helpful for me in thinking about risk and potential risk modification would be to also have some information about the proposed 2025 asymmetric risk corridor that the state has proposed to CMMI for inclusion in a 2025 extension. To Dave's point, I think at the macro level, thinking about how that asymmetric risk corridor would interact with these proposals would help me think about whether we're assuming for the moment that we're successful, the state is successful, AHS really is successful in negotiating the 2025 extension with that included, but just understanding sort of the possibility of how that would look over time. So that was just a request to kind of put this in context of what might be happening with risk on 2025. And then I'm wondering if you could go to slide 9 when you have a moment. I see you're writing. Thank you. So I understand that the last assumption would basically potentially increase potential shared savings to primary care. I think you mentioned, if I caught it, that this requires a change in the shared savings policy, potentially. If you wouldn't mind circulating the shared savings policy, I'd love to just take another look so I can understand it in that context a little better. And then for the other options, where did the dollars come from?
So for the other options, the dollars would, well, they could come from two places. An operating budget cut. So those operating budget modifications that Elena went through, if the board were to choose to cut the operating budget, you could hold the whole budget whole and say that you want those dollars reallocated to primary care, or to one of these places specifically, or have the ACO propose a way to reallocate them. That is what the board ordered last year. Another option for increasing primary care population health payments is to have them raise more revenue, which would be hospital dues. So that option would, collect more money from the hospitals that could then be reallocated or redistributed to population health.
And okay, thank you. That's helpful. And do we have any way of, I know this is a little bit tricky because there's not dollar amounts necessarily here, but do we have any way of understanding the impact on the PMPMs? Because, for example, I think I'm used to thinking about the split between the base and the bonus in that PMPM amount of 475 split between the two. Do we have any way of figuring out what the changes to those PMPMs would be?
Yes,
or do we just have like the top line sort of high level amount?
We do have that modeling, which are not in the slides, but we can circulate it, sort of what happens to the PMPMs if you do these different things. So yeah, they didn't end up in this slide deck, but we can circulate them and potentially include them next week so that the board and others can see what happens when you do these different changes.
Thanks. And do we know the other piece of information on the mental health screening and follow-up initiative that would be helpful is actually what's going on with the blueprint expansion around mental health. So I personally don't want to, if I'm redesigning a program, I want to make sure that the program I'm redesigning is still consistent with the blueprint and other statewide efforts, which is actually a legal requirement of the ACO. So I feel like I should also know that because I don't know any other way of understanding potential unintended consequences. So and I'm sure, Pat or somebody from the blueprint could send over, some information about the blueprint mental health expansion.
I don't know the timing on when we have more information there. So it's listed here as an option.
Yep.
I'm not sure, but just because of the lack of information, that it's one that I would recommend, but it is an option, and I can find out when we expect to get more information there. This was a change, last year between the submitted and the revised budget.
I think I asked this question last year too, to get the blueprint information, but it obviously didn't stay with me over the course of the year. So thank you.
Good question. Thank you.
Okay. So just for slide 11, I want to just understand a piece. So this is the source is from a national source, right? This isn't from our state-run primary X17 modeling.
Correct. Yeah, I was just going to phone a friend here because Michelle is most familiar with this.
Yeah.
For your
Yeah, and
questions.
so the part that I think is problematic for me is that the Blueprint for Health non-claims payments aren't included in this national report, because that is the way that the state since 2005 has been targeting its investments to primary care. So it feels a little disconnected to the longstanding legislative state policy. I understand this is more recent data than I think what we have in Act 17, but I just wanted to stress that caveat, because I do think that, I also, quite frankly, as I'm sure Michelle does, has PTSD from the state process of defining primary care, which we've now done at least twice, maybe 3 times, and like how much work and conversation went into that. So, I just wanted to kind of point that out, because I think that is a really big caveat that needs to be understood. It's the best we could do to get the most recent data and have a national comparison. But I also don't think that, I think that in the future, at least also having our state specific information, which has a broader definition of primary care and does include the Blueprint non-claims payments, it's just important to understand how the state has prioritized investment to primary care in general. So that's more a comment just about the, this measurement. And it, since this will be a big deal as we think about ahead, I think trying to figure out how to measure it in the, consistent, appropriate way with our state policy is important. So kind of a side comment.
And I don't want this slide necessarily to lead us astray too much. I think why we included it here is to just provide support for, a lot of discussion that I've heard or we've heard as a team around, the requirements like that I read out from the rule in the beginning, that the ACO, supports primary care. And here's just some, data that we have on, could Vermont do better in terms of supporting primary care, and the ACO is one vehicle that we have for doing that. So we
totally
provide that as context here.
I appreciate that, but this measure does not include the Blueprint or the ACO payments. So that's, it's a little bit, it doesn't really, to me, serve that purpose very well if we're not including the actual dollars that we are investing through this program in the Blueprint in the measurement, right? So we don't have to, we don't have to overemphasize it.
Yeah, no, that's fair. Yeah.
Anyway, I did have a question on slide 15. So to Dave's earlier, I guess it's more of a comment. So to Dave's earlier comment about, early on, the purpose of one of the driving forces in the PHM programs was attracting attribution and attracting participation towards scale. I think that is reflected in this graph to the right. And I think that was early on something that the state really pushed for, the state meaning all out, particularly, the executive branch, not necessarily the Green Mountain Care Board, but the state writ large had been pushing for hitting those attribution goals. I think the other piece of sort of policy intervention that is important, in addition to COVID, obviously in 20 and 21, and to some extent maybe in 22, is that their AHS did do an evaluation and a report on improvements to the ACO program, one of which was I'm going to summarize in my own words, quit chasing scale. We know we're not going to meet that. Focus now on improving the programs, make them more tailored and focused. And so I think that's just another historical piece that I think is important to take into consideration in the change between 18 and 19, which was focus on get as many people as possible in, throw money at it, to target your money to programs that might actually achieve the other goals of the model. So I just wanted to make that comment to kind of piggyback on some of Dave's comments around attribution being an early goal. I think those are all my questions and comments that I have right now. I'll check my notes and pop back on if I discover I forgot anything. Thank you.
Yeah, I'll just make a comment based on what you just said there, Robin, because I think that's exactly right and really important, between shifting the focus away from scale and the pandemic. The ACO has sort of condensed or concentrated their programs to focus more on, really willing participants. And so there are, like you see it in the story that I see in some of the charts is, if you participate on a PMPM basis, you perform, you have the ability to earn more. There's less total dollars maybe to go out, but that those who are participating can reap those benefits. So there's sort of that question about, they've sort of concentrated the programs in that way. They've kept their operating budget relatively flat. And are we still, the question remains of is that's the direction that they've moved, and are we getting the value that you expect to get from that operating budget, and are those programs providing the best number of support they can for the cost to the system. But that story certainly has removed around has evolved around, stop chasing scale and start concentrating on those who, are willing and able and ready to participate, and how can OneCare best support success.
Yeah, I guess in follow-up, I'll also just say, in looking at the budget proposal this year, I do like the change in the program to increase the weight on outcomes and moving from cutting the base payments and moving those dollars into the in the bonus potential. I thought that was a good modification to increase the likelihood of increased performance, really. The other thing I would note is that the budget, it looks like, as submitted, assumed 60% achievement of the bonus potential. So in thinking about adding dollars, I wonder if it would be, and this may not be knowable, but it might be interesting to know if 100% of the bonuses were achieved, how does that modify the budget? Right. So if we're talking about putting more dollars into the bonus pool, like the overall dollar amount would change substantially if 100% of the bonuses were achieved, which obviously you wouldn't expect that from where people are today to have that big a jump, but just to get a relative scale of that.
Yes, and I believe that number is in the ACO budget submission, because I looked at this. I think it's table 8. And they show the full amount if it would be earned. And I know that the ACO did speak to this in their hearing, saying that, those would be guaranteed payout. It's not budgeted for, but they would be paid out if they were earned. But they budget at 60%, I think, just based on past performance. But that is sort of an interesting question, is are they assuming that the participants are going to do just as well as past performance, or are they going to improve performance? So, that question has come up around, what is the ACO doing to help participants achieve better results so that they could earn more of it potentially. And if you add amounts to the bonus, doesn't necessarily mean that they're going to earn it.
Right.
And so you could be adding dollars that don't actually go out to providers if they can't achieve the results that are required for those bonus payments.
Great, and thank you for the reminder. I'll go look at table 8.
Any other board member questions or comments? I have a, oh, go ahead, Tom.
Sorry, Owen, I'll go. I want to thank everybody for the presentation and the kind of the critical thinking that went into it and the options that have been laid out. I think they're really thoughtful. And, you know, starting with this slide, I think it seems apparent to me that OneCare hasn't met its burden of proof for its budget, and I think it could be reduced substantially. And there have been some changes this year that Robin was just speaking of, about changes to the bonus versus the base that I think are promising, but there's still a lot that's kind of lacking. You know, there's still no way that I can see to link an activity or a program that OneCare is doing to a meaningful health outcome, and so that's causation. But I'm not talking about academic causation. You know, we're not going to do a randomized trial, and not going to have instrumental variables, all that kind of nerdy stuff. Just kind of kitchen table causality. They found in their analytics that X was suffering, and they started Y to try to make it better. And then they looked at X again and saw that it was better or it wasn't better. So then they're trying Z intervention. And even that basic type of conversation, even though this has been ongoing since 2017, 2018, I can't see any evidence of that. And at the same time, there have been other unexpected changes that have happened in the healthcare system. And so it's hard to, I said this last year, it feels wasteful to me to keep approving a budget where we can't see evidence that it's causing the desired improvements or stopping deterioration across the system. Right? It's like things have been changing in the healthcare system in Vermont, starting before the pandemic, through the pandemic, and those changes have been happening not because of an ACO intervention. They've been happening while we've had an ACO. The ACO agreement was supposed to help increase providers' willingness to take on risk. We haven't seen growth in risk tolerance. So I really have a hard time approving the budget as is. And I think the next slide had options for how to deal with that. Right. So I think that's, I'm sure over, you know, during the next week, we'll have some debate about this, but I think we need to look carefully at the operating expense, because I think it's proven difficult to identify what OneCare is doing other than the redistribution of federal dollars coming in and then going out. I think we have to keep in mind we can't cut the budget so much that it kills the organization. There are other things that it's vital that it keeps doing, accepting the money that comes in and following the money going out. The best analogy that I've been able to come up with, and this kind of, I think Dave touched on it in his, it's as if as a state we kind of launched a plane in, you know, the mid 20 teens, and said, here's the direction that we're heading. And as the plane had trouble lifting off, had trouble getting enough air in its wings, a number of attributable lives. And there have been malfunctions as it's gone, and it's ran into a big storm with the pandemic. But at this point, I think it's time to recognize that it's not going to get where it was headed. And it's malfunctioning, and there are other unintended consequences happening to the healthcare system. Now, we can't shoot it out of the sky, and we don't want it to crash. There are things that are happening, bringing money in. So we have to find a way to help it safely land. And how do we do that? And I think that's where the thinking about redistributing some of the money and making sure that we're increasing our funding of primary care. That's where the care happens, where the hot spotting or rising risk identification can happen that can keep people out of the hospital, the things that ACOs were supposed to help do. I know there's trouble finding ways to make sure any redistribution actually makes it to primary care. But I think trying to think about, well, let me pause. I don't think it's time to just be taking money out of healthcare in Vermont. We have terrible difficulty with substance use disorders, suicide. There's hard to find values that are meaningful to Vermonters that are improving. So just cutting the operating budget and pulling that money out of healthcare delivery, I think, is unwise. I think redistributing it, finding ways to redistribute it, is a wise thing to do. I think the entity of OneCare itself should have some risk on it, for regardless of the size that it may shrink to, that it delivers to providers useful information that they can use to adjust their care processes in order to hotspot, identify patients with rising risk, and try to keep those patients out of more expensive care. So I really liked the idea of the 1% change being onto the OneCare entity. I think the 100% risk, Dave was alluding to this, doesn't seem realistic. They've already refused to do it. We asked them to in our guidance, and they did not. So I think modeling what if they did and they increased the risk score, I don't know that that's useful time, because they've said they won't. But maybe a 1% increase they may consider, because that could bring more money in, again, to the providers, that can be distributed to the primary care providers. And it's not time to be taking money out of the healthcare system. I think it's a good time to be thinking about how do we get it to primary care. And then the third thing that we were talking about, so that was modifying the risk corridor. I don't think, I'm not comfortable approving the budget as submitted. I think the risk corridor should be modified up to 4%, and that 1% should be at the ACO level. The third option that we were talking about, could we see that slide again, please? Yeah, modifying the investment in primary care. Could we go to that final slide? So I've been looking at this slide. There's a fundamental concept with accountable care that I do believe in, and that's having more accountability on providers, rather than a fee-for-service model where you get paid every time you do something. There's some accountability necessary, some risk necessary to come onto us providers. So if I think of that as a starting place, and we're going to increase support of primary care, increasing the bonus payment seems like an idea that's aligned with increasing shared risk. Increasing the base payment, because it's guaranteed increased funding, that does not fit my mental model of what alternative payments are supposed to do. Same with splitting the amount. There's guaranteed funding there. Increasing mental health screening. Screening is such a soft target, and screening, you'll identify more, but without any system behind it to increase access and usefulness, it's likely to become a measure that produces more angst than good. And so the final thing, the 1% upside, 4% Medicare corridor, I like that provides the largest amount of increased funding, and there still is risk involved. That fits the definition of an alternative payment model. So kind of in summary, I'm against passing the budget as submitted. I think the operating expenses, we need to recognize that the plane has had difficulty from liftoff. There have been malfunctions along the way. It's not going to get us where we want it to go. It needs to land safely, but continuing to invest in it as if we think it might get us where we want to go, I think is wasteful and doesn't really jive with what we've seen. Increasing the risk corridor has such a big effect on money that can come in, and is likely to prove to be successful. I think that's a wise thing to do. And I think either of the two, increasing the bonus payment or the 1% upside, either of those two things kind of fit my mental model of alternative payments. So thanks again for the critical thinking and putting together a presentation that really outlines steps that help me think through things.
I just want to, I don't have a lot to say today. I've really been in listening mode, trying to hear other board members' perspectives. And obviously I know, Owen, you haven't gone yet. But so I'm really in listening and digesting mode. There's a lot of analytics here that I want to take some time to unpack. But I do have a quick question for the staff. If there's some conversation around, which there does seem to be, modifying the Medicare risk corridor and potentially putting that risk at the ACO level with the reliance on the reserves to cover that risk. One thing that would be helpful for me, if it's possible to learn more about, and again, this is not a question for today, this is a question for if there's a way to uncover this information. It would be really helpful for me to understand the source of the increase in reserves over time. If we look back, it's 2018, it was 3.9 million, and now it's 8.4 million, if that's the estimate today. I'd like to understand how that's grown over time. What's the source of the dollars going into the reserves? And if there's any known restrictions on those reserves held by the ACO. So that would be helpful to me to understand a bit more about the reserve. So that's my only question, homework assignment, so to speak, for the staff. I have my own big homework assignment here in unpacking some of these numbers and thinking through what I've heard from other board members and seeing where I land. Not the plane, Jessica.
We might be able to answer that now, if Elena or Matt have that. I don't have that answer at my fingertips, but we did look into that. The original, the 3.9 million that in 2019 was board ordered to cover the Medicare risk. for hospitals. And the board has not increased that amount, but the amount has increased over time. So, okay, so Elena Pavlov, if you
Yeah.
are able to answer
So,
that to any
and-
level.
Yeah, I can start to address it, but I think it will require some more digging. So it has increased over time. It's not clear if it's just more revenue or fewer expenditures than budgeted, but basically, you know, when you have a net profit or surplus at the end of the year, it can go to reserves. And we can dig up, I think the board did pass some requirements a number of years ago, so we can share that and kind of do a variance analysis for you year over year to see if we can identify some key drivers, but I think we would need OneCare to kind of look at that and offer anything that we may not be seeing directly.
Thank you.
One question, if you can't answer it now, we can get to it another time. On the bonus payments, they budget 60% of folks will hit those amounts, and they have then a dollar amount correlates to that. What happens with these bonus payments if it's 25% and they end up having to spend a lot less of the money that was budgeted for bonus payments? Where does that money go?
Yeah, I think it becomes deferred payments that can be reallocated, but I'm not 100% sure. I'd want to check at what happened to the past. If they're not, I mean, during the comment period, if OneCare wants to answer, I think that would be fine. Yeah, if it's not paid out as budgeted or below, you know, how does that get reallocated in the budget? If we can't answer it now, we can get that answer for you.
Okay. And then I guess the way I'm thinking about this is at what level, if any level, did OneCare hit their burden of justifying the budget? Is it a $10 million level, an $11.8 or $9 million level, a $13 million level, a $14 million level? And I am struggling at which level, if any, they satisfied. Like, where is it, and how do we think about that? And then sort of from a larger point of view is over time, you do want to see risk levels increase, because with increased risk, the state brings in more dollars. And over time, as the ACO has matured and its programs have matured, we would hope that the performance would improve as you evolve what you're doing. So you would hope to see increased risk, which would draw in more money and maximize how much money we're bringing into the state through Medicare, which would be a good thing. The other thing that sort of jumped out to me is the primary care level of support. On slide 10, I think it was in absolute dollars, it was from 16 million down to 12.8. But if it were $16 million adjusted for inflation and it had held steady, that would be quite a bit higher than 16 and surely a lot more than 12.8. And so our providers are seeing presumably about the same number of patients, but the amount of money they're receiving through the ACO program is declining quite significantly for that population. And if we look at setting aside the slide about total cost of care spending on primary care, if we look at the benchmark performance for the quality measures for primary care for the ACO that we saw, I think last week, that they are all three of those metrics, I think there are three, were a pretty steady decline. So the money is going down. The patients that people are seeing are staying flat, if not up, and the dollars are not there. So if we are serious about supporting primary care, we would like to see these numbers a little bit different. Just another sort of high level thought I had was on attribution. It's a little, I don't know what to think of it, but you know, UVM has a Medicare Advantage plan. Medicare Advantage hurts attribution for the ACO. UVM is the parent company to the ACO. And every night I watch the news, I see a number of ads for UVM's Medicare Advantage plan. And I just think when I watch those ads that this is going to hurt attribution to the extent that those advertisements are successful at drawing people into the UVM MVP Medicare Advantage plan. The other thought I had on attribution was that there is competition from other ACOs that offer quite a bit more for primary care, or at least on some level offer more for primary care. And we're seeing some FQHCs go that route. And it seems like that could actually hurt this ACO's attribution as well. And if those people are getting more support from those ACOs, I think that could also hurt attribution going forward. So I think at a high level, we're seeing less risk, we're seeing less attribution, and we're seeing some money from the federal side left on the table. And that's not exactly where we want to be. Having said that, there are some improvements, I think, this year over last year, pretty important ones. I think the bonus increase is really important. And I like that. I like some of the focus on the measures. I thought that was really beneficial. And so that's where I am as of now. I think ultimately I would support finding that OneCare had met their burden as to a lower level of budget. And I would support trying to put this money in the pockets of providers trying to provide care, as opposed to administrative costs for administering this program, because I don't think we're seeing the return that we had hoped. And that's all I have for now. I'll turn it to the healthcare advocate.
Nothing else from us, Chair Foster. Thank you.
Great. And I'll open up to public comment. Mr. Boris, and I'll just introduce you as I believe you're the CFO of OneCare. Please go ahead.
That is correct. Good morning. 6 minutes, everyone. Thanks for the opportunity to speak. I'd like to just address a couple of the topics that came up. I think it was a good, robust discussion today, and it's going to feel a little scattershot because my notes kind of were written along the journey of the talk today. So first, on the operating budget, just a couple comments to make. I really struggle with the reference to attribution. I understand why that's a kind of a natural way to think about the budget, but as Marissa accurately stated during her discussion, our operating budget and even the PHM expense budget in total has remained relatively stable through time. That's a key part of our strategy because the hospitals have to pay the participation fees to keep this work up and running. If we linked our operating budget and PHM budget too directly to attribution, which does move around through time just based on industry trends and dynamics, it creates instability in our budget, meaning that one year we could have operating expenses go up and the next they go way down. From just a business standpoint, that's a really tough paradigm to work in. We'd rather have a more stable budget and plan through time so that we don't have these kind of fluctuations as attribution moves from redetermination, Medicare Advantage, payer participation, et cetera. So I think that's just an important dynamic that I often think about when this comes up. Also would like to just echo the comments around the pandemic. We really tried hard in that pandemic period to manage the costs borne by the providers. Tough times for everybody. So we thinned out some of the initiatives that we had planned to bring it down to that level. And then again, as Marissa noted, we've been really stable from that point forward. Next on the operating budget, I think it's really important to note that the operating budget and the PHM expense budget complied with the Green Mountain Care Board guidance. We did that deliberately, thinking that this is exactly what the Green Mountain Care Board wanted to see. So therefore, I don't think any changes or modification to either the PHM budget or the operating budget are warranted, because again, we did comply with the guidance as given. Lastly, on the programmatic breakdown, I think Dr. Merman brought this up. The OneCare team works in a very dynamic way on all of these initiatives, and for us to have them do time tracking or other administrative functions to monitor which initiative and which program they're working on at any point in time would be incredibly burdensome for the staff. So we really haven't gone to here's a CPR budget. We budget by team. It just works a lot better for the way that we're structured. Next, I'd like to speak a little bit about risk, which came up a lot here. Candidly, tough topic. I mean, risk is, there's no right answer. There's no wrong answer to identical two people in identical circumstances can have a very different risk tolerance just based on who they are, how they think about the world. And we feel that within our network. Some are ready to expand the risk corridors, others are not. And we're often in the place of trying to keep the mass of the network together so that we can keep this initiative up and running in large scale. And increasing risk has a con or counter risk, which is that we could lose participation. So I think it needs to be thought of really carefully in this space. You know, there's certainly years where I have thought maybe we should increase the risk corridors, but we got to measure that against the provider willingness to take on more risk. And that's a complicated evaluation in itself because it's relative to the financial health of their organizations and what they think healthcare patterns might do into the future. Another question came up around the public health emergency and how risk was managed there. The way that CMS was modifying ACO programs across the country was to link downside risk to the public health emergency status. This is a federal designation coming from Washington, D.C. And there's no risk until that public health emergency status ends. But we did not know when that was going to be. Every quarter, we're kind of waiting to hear if they extended the PHE or not. So in retrospect, there was not risk in those pandemic years, but we didn't know that until the year concluded. So it created a very challenging dynamic. Next comment. Around the ROI calculation, there's a question about the shared savings level. Just to note that the evaluation team that looked at the ROI included both shared savings and also the benefit under the fixed payment arrangement for Medicaid. So that's not shared savings technically, but it's financial benefit to our providers. Next, risk adjustment in the Medicare program. There is not a direct risk adjustment in that Medicare program. There is, however, implicit factoring in of coding increases in the Medicare's USPCC fee-for-service trend. When they're looking at the national expected healthcare cost growth year over year, they recognize that there is coding improvement activity going on across the whole country. So it's implicitly baked into that trend. Next, I'd like to speak about OneCare versus some of the other ACOs. Difficult comparison. I don't know everything about how they're funded and financed, but we're financed by our providers, and we have to make our financial decisions with that in mind. We don't have any kind of capital behind us other than what our providers are willing to invest in this work. So I just need to say it's a really different dynamic. I think, there was a press release recently about an ACO that formerly operated in Vermont, and they're getting out of the ACO business because they can't be profitable. That to me says an awful lot about the difference between OneCare and some of the others. Mental health screening and Blueprint. We are working in partnership with Blueprint on that initiative to make sure that we are very aligned. And I think this is a good opportunity for us to bring some of our value to the table, some of their value to the table, and do some great work. And then, Chair Foster, you mentioned unspent PHM. We spoke about this in our submission documents, so I'll just refer you there. There's a good explanation. Go ahead.
Great, thank you very much. That was really helpful. Any other public comment? Okay, hearing none. I think we are scheduled on the agenda to adjourn until 1 o'clock when we have Pat Jones from AHS presenting with Michelle Degree. So why don't we adjourn till 1 o'clock and we'll see everyone then. Thank you. It looks like we have everyone, so we can resume our hearing. And we're joined today, this afternoon, by Pat Jones, the Interim Director of Healthcare Reform at the Agency of Human Services, and also Michelle Degree, our Health Policy Project Director, who will provide an update on the all-payer model and global payments. I'll turn it over to Michelle and Pat, and thank you for being here today.
Thank you, Chair Foster. Pat, I will go ahead and share my slides for you. Just let me know when you'd like me to advance. And I will also note that Wendy Trefton from the Agency of Human Services has also joined us today, and she will also be presenting with Pat.
Thank you so much. Thanks for asking us to be here to provide another update on where we are with a potential future federal model called AHEAD. So you can go ahead and advance, Michelle. And again, I wanted to start by just giving a brief summary of where we are with the current model. I think